So my name's Roua. I'm one of the FY1 trainees currently working at Birmingham Children's Hospital. And today I'll be discussing an interesting case of vasculitis. This case was followed up by Dr. Islam Al-Abadi, who was unable to attend today. But really what I'd like to do is focus on, or what I'd want you guys to focus on, is just the subtle and key rare features in this case, because that's basically what we'll be discussing. So I'll keep it short and sweet due to time. So our patient, she's a 9-year-old Caucasian female. She initially attended A&E with a unilateral facial droop and transient expressive aphasia. And a little bit about her background history. She had a 2-month history of twitching of the hands and the feet, and a 3-day history of involuntary twitching or rhythmic movements of her arms and her hands. So it'd be important to note here that in terms of the 2-month history, it was sort of an intermittent course with issues that would come and go. So the reason she came to A&E was really because she had this acute unilateral droop and the issues with the speech that her teachers had noticed. Other than that, there was nothing else that was significant in terms of her history. Her past medical history, she has a history of emotional problems and persistent tearfulness at school. She's also known to have anxiety, but no known medical conditions. And in terms of her family history, her mother has a history of long-term chronic illnesses, and on one occasion she had a pulmonary embolism due to no apparent cause, but nothing else that was significant at this point. So in terms of her general examination, she was alert, oriented. She was noted to be overweight or obese, communicating in an age-appropriate manner and slightly emotionally labile. And on her observations, she was tachycardic, hypertensive, but everything else was stable. So in terms of the systemic examination, the A&E doctors, they really just honed in and focused on the neurological findings and found that she had dragging her right foot when she was walking, intermittent florid chorioathetoid movements of her fingers and her arms, a subtle right hemiballism, involuntary twitching of the lips, and protruding movements of the tongue. But everything else was normal, no other neurological findings, cardiovascular was fine, abdominal examination was fine. So in terms of investigations, a few baseline investigations, really the findings that were found was that she had anemia, thrombocytosis, neutrophilia, ESR was slightly raised, CRP was high, ASOT titer was positive, B12 was low, everything else was fine. So in terms of inflammatory markers, it wasn't screaming inflammation, it was just possibly infection, nothing that was really telling. So this is a beautiful list of other investigations that were negative. So at this point, nothing else was found. So really, the neurological doctors, consultants, they narrowed down the differentials into this: possibly a basal ganglia stroke, Sydenham's chorea, Crest syndrome, autoimmune encephalitis, or a possible pervasive developmental disorder. So nothing that involves, the experts at the moment. So the first imaging test that was done was an MRI scan. So you can tell by the right image that she had initially a few microinfarcts on the left side of the hemisphere, but really the incidental finding that I'd like to highlight is on the right image, you can see narrowing of the vertebral arteries just before they form the basilar artery. So that was something that caught the radiologist's eye right here. And then made them question, is there a vascular pathology going on? Maybe this is bigger than it seems. So then they decided to do a CT angiogram. And two things that were noted, again on the right image might not be very clear, but the common carotids were quite narrow. But really what I'd like to also highlight is the right image, which shows narrowing of the superior abdominal artery, or aorta, sorry, that's when they really thought, okay, there's definitely a vascular pathology going on. But
just that focal segment?
yeah, just that area there. So really they narrowed down their differentials into, is this a congenital vasculopathy or is this a large vessel vasculitis? And so the best way to differentiate this, according to radiologist's advice and rheumatologist's advice, was to do an MRA. And here you can clearly see what we want to see is the synotic changes of the common carotids and the post-synotic dilatation, which is quite visible, more prominent on the left side than the right. But at this stage, they were absolutely sure that this patient had Takayasu arthritis. And so in terms of treatment, I'll touch on it a little bit. The patient was started on methotrexate once weekly, subcutaneous injections, and a high dose of prednisolone and antithrombolytics, so she was given warfarin. So really the learning points from this case are that a third of Takayasu arteritis cases can present with a relapsing and remitting course, as seen in this patient. So that would be something to sort of focus on in terms of patients who present atypically with not the typical symptoms of vasculitis that come and go as well. The subtle changes to the vessels on CT and MR angiography should also not exclude the diagnosis of vasculitis. So this was a nice thing that they found it on the first initial MRI, and then they decided to explore that further. And obviously, early recognition leads to early treatment, which is what was done for this patient, which is great. And then the third thing is that normal inflammatory markers does not exclude vasculitis. So this patient, again, her initial blood tests weren't screaming inflammation. They were high. I wouldn't say that they're normal, but it wasn't what you would typically find in a patient that has vasculitis. And the last one is that waiting for the involvement of large vessels in the presence of medium-sized vessels can delay the diagnosis and treatment. So thank you very much.